And I'm starting the stream. All right, the stream is up. We'll have to wait and test the captions again.
Okay, I can see those captions coming through. That's good. So Craig, do you want to go ahead and make me the host now?
Yeah.
I'll make you the co-host again.
Come on. Okay, George, you're the host now.
Okay, I'm going to start letting people in, and I'm going to start the recording now. Okay. Good morning, everybody who's just joined us. We'll get started in a few minutes. Good morning for everybody who's just joined us. Just to let you know, we are recording, and this is being live streamed to the DARS YouTube page. morning for those of you who just joined. This is the Public Guardian and Conservator Advisory Board annual meeting. We will get started in just a few minutes, but I'll let you know that we are recording this, and this meeting is being live streamed to the DARS YouTube page, so your voice and image may be captured. Okay, good morning. I have 10 o'clock, so we'll go ahead and get started with the housekeeping, and if anybody else joins, I'll let them in as they come. So this is the annual meeting of the Public Guardian and Conservator Advisory Board, also the fourth quarter meeting. I will just run through some housekeeping announcements, and then I will turn it over to our chair, Rose Palmer. So due to the active state of emergency, this is an electronic meeting pursuant to item 4-0.01 of the 2020 Appropriation Act. Meeting notice has been provided. The meeting is being recorded and minutes are being taken. All votes will be conducted via a roll call of voting members. Meeting materials are posted under the Public Guardian and Conservator Advisory Board's quarterly meeting tab at the link posted in the slide. Members of the public are able to live stream this meeting via the DARS YouTube page. Please be advised that if the live stream is interrupted, we will need to pause the meeting until it's restored. Public comment will be accepted by email or phone to my attention. Public comments that were received by yesterday, June 21st, 2021, will be read or lengthy summarized during the meeting when we reach that agenda item. We'd ask that members please keep your microphone on mute unless you are speaking. This helps reduce background noise. Also, before you speak, if you could please state your name, as this helps your colleagues know who's speaking, and it also helps my colleague Cecily Slather with documenting the minutes. This is particularly important as committee members will be discussing recommendations and board members will be discussing recommendations and our captioner will be trying to capture those discussions. Members and guests, if you have your video enabled, please be aware that the system may capture your image and video in the public streaming and recording. Please only use the chat feature if you have a technical issue or other issue not related to the business of this meeting. Chat comments are not captured in the live stream or the recording and so are not available to members of the public. If you'd like to view the real-time captioning of today's meeting, please click on the CC button on your Zoom menu bar and select Show Subtitles. Zoom participants will be able to turn on or off closed captioning. The YouTube streaming will automatically include the captioning. For all votes, we will do a roll call, and you'll be asked to indicate your support with an aye or a yes, opposition with a nay or a no, or you may abstain. And I'd like to thank the DARS video teleconferencing team and the DARS communication team for making this electronic meeting possible. I'll go ahead and do a roll call of members to confirm attendance. I'll do this in alphabetical order. James Almond. I see him here, and maybe he's having trouble unmuting.
I'm here.
Betty Doherty. Oh, you're here. Great. Thank you. Thank you, Judge Almond. Betty Doherty. Betty, if you're speaking, you're muted. You see her in the list. So, Susan Elmore.
Yes, sir, I'm here.
Thank you. Kathy Harkey.
Present. Good morning.
Good morning. Kimberly King.
Here.
Monica Karavanik.
Here.
George McAndrews. He is just joining us. Rose Palmer.
Present. Good morning, everyone.
Morning. Angie Phelan.
Here.
Lindsay Pickrell.
Good morning, I'm here.
Tara Ragland. Latoya Roxburgh.
Here.
Thanks. Ming Truong.
I'm here. Good morning, everyone.
Erica Wood.
I'm here.
And Christy Zed.
Here, good morning.
Right, so we do have a quorum. We have almost everybody is here today, which is great. So I'll turn it over to you, Rose.
Thank you, George. Without further ado, let's get started on our meeting. Meeting was called to order at 10:05 a.m. One member of our board is rotating off at the end of June, Angie Phelan, who has ably represented the Virginia Association of Area Agencies on Aging, or V4A, for 2 terms since 2015. And I'd like to thank her for her service and contribution to the mission of this board. We really appreciate everything that you have done, Angie, and we will miss you.
Thank you. Thank you. It's been a pleasure to be on the board with such a great group of people.
Glad to have you. We are truly going to miss you. Moving on, we have time to review and adopt the meeting agenda. Has everyone had an opportunity to review the agenda?
Rose, do you want to ask members to introduce themselves?
Oh, I'm so sorry. I'm moving right through because I know we have so much on the agenda today. Would everyone, let's start with, you want to just do a roll call for the introductions?
Sure. So start with Judge Almond.
Hello, I'm a retired circuit court judge. I've been on the board for 7 years.
Yeah.
Can you
Betty
hear me?
Doherty. Yes. I do see Betty there, but maybe she's unable to unmute. Susan Elmore.
Hi, good morning. I'm Susan Elmore, and
I'm been a professional in the field for a number of years, and this is my second board meeting.
Kathy Harkey.
Morning, I'm Kathy Harkey, Executive Director of NAMI Virginia. I'm pleased to be with you all again today.
Kimberly King.
Hi, this is Kimberly King. I'm a Community Integration Manager with the Department of Behavioral Health and Developmental Services.
Monica Karavanik.
Morning. I am the Director of Operations at the Arc of Southside in Danville, Virginia, and I occupy the seat for the Arc of Virginia.
George McAndrews.
I'm George McAndrews. I'm an assistant city attorney in Alexandria. I've represented our mental health department for years and handled guardianship issues for years. And I think I've been on the board for 6 years.
Angie Phelan.
Angie Phelan, and I work at Senior Connections, the Capital Area Agency on Aging, and I'm representing the area agencies on aging for the state.
Lindsay Pickrell. You're muted, Lindsay.
Sorry about that. It wasn't working. I am Lindsay Pickrell. I'm the Virginia State Bar representative. I'm an attorney with Thompson McMullen in Richmond.
LaTroya Roxburgh.
Yes, I'm LaTroya Roxburgh. I'm an LCSW. I have a private practice and a small mental health agency where I'm the clinical director here in Richmond, in Richmond, Virginia.
Ming Trung.
Good morning, everyone. Ming Trong from Virginia Beach, and I am work for Department of the Navy. And my voluntary job is director of the senior club here in Hampton Roads. And good to see everyone today.
Erica Wood.
Good morning, I'm Erica Wood, and I'm a member of the Virginia Commonwealth Council on Aging. And the Commonwealth Council has a slot on the Public Guardianship Board, and I'm filling that slot.
And Christy Zed.
Hi, Christy Zed. I am the Chief Operating Officer for Developmental Services at Richmond Behavioral Health Authority, and I am representing the Virginia Association of Community Services Boards.
And guest, Marcia Dubois.
Good morning. I'm Marcia Dubois. I'm the Deputy Commissioner for the Division for Community Living, and happy to be here.
Patty Mary.
Hello, everyone. I'm Patty Meir, and I'm the coordinator here at DARS for the Virginia Public Guardian Program.
And Betty Vines.
Good morning, everyone. Betty Vines, Public Guardian Program Specialist here at DARS.
I think that's everybody except yourself, Rose.
Thank you, George. I appreciate that. It's a little easier to do it that way. I am Rose Palmer. I am the chair of the board. I'm going into my second term as chair. I am a member at large of the board, and I have been on the board, I think 5 years and working toward my 6th. Thank you. Okay, now let's take a look at those the meeting agenda and see if we've got an approval. I do have 2 changes. The nominating committee item should be not a nominating committee report, not appointment of members, and Monica Karavanik will be providing the report. It should also include an action item to elect the new officers, and the election will require a roll call vote. The other is to include an item to appoint the legislative committee. I'd like to add this in and after the nominating committee report. May we have a motion to approve the agenda? You do have to unmute.
Motion to approve the agenda.
Do we have a second?
This is Angie. I'll second.
Thank you. And George, if you would handle the roll call, please.
Sure. So the motion is to approve the agenda with those two items. I've just amended it to reflect the two items that Rose mentioned. So I'll do the roll call alphabetically. James Almond.
Yes.
Susan Elmore.
Yes.
Kathy Harkey.
Yay. Yes.
Kimberly King.
Yes.
Monica Karabanik.
Yes.
George McAndrews.
Yes.
Rose Palmer.
Yes.
Angie Phelan.
Yes.
Lindsay Pickrell.
Yes.
Victoria Roxburgh.
Yes.
Ming Truong.
Yes.
Erica Wood.
Yes.
Christy Zed.
Yes.
Okay, the motion is carried and the agenda is adopted as presented, as amended.
The next is to review and approve the minutes from the last meeting on March 16th of 2021. If everyone would take a minute or two to review those now.
Good morning, Rose. I just wonder on page 6, is that a typo about the contract end on June 30th, 2016? Or 2021? I just want to make sure that's correct year.
Yeah, Patty, should that be to 2021?
Yes, what we were talking about there is the base contract was created for FY17 and ends this year. Yes.
Okay.
It's been renewed 5 times. Yes. So I think changing that to 2021 would work. Yes.
Okay.
Are there any other changes or corrections? Since it appears we have one change, when you're presented with the roll call and your name comes up, please answer the minutes are adopted with the changes proposed.
Rose, we don't actually need to do a roll call for this one, so if you can just adopt them as amended.
I've completely forgot that. We've changed that. The minutes are adopted with the changes as proposed. I get to do it.
Okay.
George, are there any public comments?
No, Rose, we didn't receive any.
Okay. Marcia DuBois, we would love to hear the division for the community living report.
All right. Well, good morning, everyone. Again, I have some good news to share this time. That's always good. some of it regarding funding. So the first piece of new funding that we received was for our area agencies on aging for vaccine relief. And that was 1.2 million in vaccine funding for activities such as disseminating credible information about COVID-19 vaccine and help to direct those with questions to additional resources and sources of information, identifying people who may need help getting a COVID vaccination, helping with scheduling a vaccination appointment for those who need help, arranging or providing accessible transportation to vaccination sites, providing technical assistance to local health departments and other entities on vaccine accessibility, providing personal support if needed, and reminding the person of their second vaccine appointment if needed. So those are just some examples of activities. Our area, our 25 AAAs or area agencies on aging had already been engaged in this effort for some time. They've been doing things like distributing flyers, posting information on their websites and Facebook pages, answering calls, hosting virtual town halls, contacting current clients. Most had already been working with their local health districts and emergency management providers, providing volunteers, assisting with call centers. Several had even set up their own vaccination sites, and all have been providing things like transportation. Much of our effort has centered around Kathy Miller here, our Director of Aging Programs and Services, have been working with representatives from the Department of Health, Department of Medical Assistance Services, and the Department of Behavioral Health and Developmental Services to establish a strategic plan to safely vaccinate those who are homebound or medically fragile, and to work closely with the AAAs on that, who had been working, of course, with their local departments of health to identify folks and make sure that they had worked out a plan to reach people in their homes who were not able to safely leave their homes to get a vaccine, those who wanted a vaccine. And so that hard work has been going on for months now. So in addition to that, our No Wrong Door program also receives some vaccine funding to do some outreach activities along the same lines of some of the activities that I mentioned there. In addition to that, the American Rescue Plan also awarded DARS with nearly 34 million in COVID relief money passed by Congress to speed up the recovery from the economic and health effects of the pandemic and ongoing recession. And much of these funds for the area agencies on aging will help deal with the increased demand for Older Americans Act services such as nutrition, home delivered meals, in-home services, some of the services through our ombuds program, our disease prevention programs, our caregiver services. So we know that this will help really meet the growing need for these critical services. This funding will be awarded to Virginia area agencies on aging as soon as it's appropriated in July upon the reconvening of the General Assembly. So that will be a big help there as well. Also wanted to share with you all some exciting news about some of the grants that we've been working on. Our team has been really active this spring in writing grants, and we received some good news that we have been awarded through the Administration for Community Living our 2021 Empowering Communities to Reduce Falls and Falls Risk Grant to expand our falls prevention program, a matter of balance and bingo size across the Commonwealth of Virginia. So both of these programs can be held online or in person. And the award amount is $287, almost $288,000 for a 3-year grant period that runs May 1st of this year through April 30th of 2024. So Virginia was only one of 11 states that received that grant. So really, really excited about that. And once again, to partner not only with our area agencies on aging, but some other programs as well to deliver those services. In addition, many of you are aware that we've had our lifespan respite program for many years that allows us to give just a small amount of a respite voucher to caregivers. And we did submit a new lifespan respite grant proposal to continue this important effort. It's a 5-year grant opportunity through, again, the Administration for Community Living for over $1 million. So if awarded, DARS will use the funding to reach underserved populations and increase the respite voucher rate for recipients. So I hope you'll join us in really keeping our fingers crossed on this one, because it's a really, really important program. And through the pandemic, we've really seen caregivers take on, they had a huge burden to begin with, and they've taken on much more of a heavy load throughout the pandemic. So we're really hoping that that we can provide just even a tiny amount of additional relief for this really important effort. And finally, we've done something we've never done before. DARS has applied for HUD grant, and this is for home modifications for older adults through the Department of Housing and Urban Development. And this would be a 3-year grant opportunity. And if awarded, it would allow Virginia to expand home modification programs for low-income elderly homeowners across the state in areas that are considered substantially rural by HUD. And it would involve at-home assessments of individuals' homes by a licensed OT or occupational therapist to evaluate the older adult's home and allow them to pay for repairs or home modifications that would be $5,000 or less. And so due to the substantial rural requirement of the program, DARS chose to partner with area agencies across the Commonwealth that serve areas that are rural and who have already had experience in providing housing modifications. And this list includes Appalachian Area Agency for Senior Citizens, Bay Aging, Southern Area Agency on Aging, and Eastern Shore Area Agency on Aging. So we're really hopeful that we could get our foot in the door with this program, because we know that sometimes the thing that can keep the person in their home and out of a nursing home or costly institution is just a small housing modification, just being able to maybe return from rehab and being able to stay in the home with just widening doorways or maybe a small wheelchair ramp. So we're excited about it. And finally, I just wanted to give a shout out to our partners at the Virginia Association of Area Agencies on Aging, who joined with us to host the 4-day virtual Governor's Conference on Aging, May 24th through 27th. So it was a 4-day virtual conference. And for those of you who were able to participate, it was really fantastic. More than 300 people participated, and recordings are still available for folks who attended, but there were really just a lot of vibrant, rich sessions. And we really felt like, considering that it was virtual, it was really fully packed. And so we just wanted to get a shout out to V4A. So thank you all. I want to apologize in advance. I always enjoy participating in this whole meeting, but I have another meeting. So if you see me drop off, it's not because I don't want to be with you all, but I do have another conflict. So thank you all. It's good to see you.
Thank you so much. We appreciate your report. I do have one question, and others may have questions as well, but has there been any outreach as far as isolation during the pandemic for our aging citizens?
Absolutely. I believe that I mentioned it the last several times, and I think that George may have sent out links, but certainly our area agencies on aging have been doing phenomenal work with addressing social isolation, even throughout the pandemic. Really a lot of creative activities, and both their association as well as DARS have produced a whole series of promising practices, really highlighting and showcasing some really creative work that they did to really try to reach people and get engagement, not just through things like, virtual Zoom, but they did car parades, just all kinds of things. And so there were a number of publications that we put together, and they've been shared nationally. The area agencies have been recognized nationally by the National Association of Area Agencies on Aging for some of their really creative work in reaching people and getting them engaged, so they weren't really isolated and lonely during that time. And what I'll make sure I do is get that to George again. At not only our links, but the document that the area agencies on aging put together as well, that showcased not only activities they did, but also just individual stories that were really compelling about, how folks were really touched by the services that were provided to kind of get them engaged. And I think that's why we saw, I think it's a great question, first of all, Rose, but also why we've seen an increased demand. At a time when you think maybe that wouldn't happen, it wasn't just because of home delivered meals and things like that. I think it was because people and families saw a need to have their family member be connected with something. And I think we've seen our programs really rise to the occasion.
I appreciate that. And I'm sorry if I missed that in some of your reports, but I appreciate you restating it.
Sure,
And
have them send out those links so you all can read at your leisure.
thank you so much for all you do for us. And the grant opportunities and the grants that have been received are phenomenal. We couldn't do it without you guys. Thank
I'd
you.
be happy to answer any other questions as well.
Does anyone else have any other questions? If not, we'll move on to the Public Guardian and Conservator Advisory Board bylaw revisions. George, do you want to pick that up? Thank you, Marcia.
Thank you.
Sure. Thanks, Rose. So I'll just pull them up. With me a second. Okay. Members will remember that at the last meeting, we presented the bylaw, or I presented the draft bylaw amendments for the second time, as required by the bylaws in currently operating. Members noted a number of small changes that needed to be made, so I took all of your suggestions and recommendations and have incorporated those. So I'll just summarize those very briefly for you. There were kind of three main points that were raised. So one was that some of the definitions weren't put into the bylaws at their first instance. So for example, in the second paragraph here, section 1.2 under purpose, you can see the purpose of the board is established by the Code of Virginia shall be to report and advise the Commissioner of the Department for Aging and Rehabilitative Services. So that's defining the Commissioner and the department. I think those were the only instances of definitions that needed to be clarified. There was a bit of boilerplate from the DAR's recommended bylaw changes that was left in, and that has been updated to show that this is the the board, meaning the Public Guardian and Conservator Advisory Board. And the third change was there were some references to the executive committee, which had actually been excised from this version of from the draft bylaws. So those have been removed and replaced with references to the chair. So I won't go through the summary of major changes to the bylaws, since I did that at the last meeting, unless anybody would like me to review those again. Everybody received these with their meeting materials, so hopefully you've had a chance to review them. And
Good morning, George. This is Ming. I like the format you revised. It. Great work. Thank you so much. I have a question for you regarding the section 5.7 electronic participation. And you sent the attachment. So the attachment is a part of the bylaw or just, attachment by itself? Thank you.
So thank you, Meng. So the Public Guardian and Conservator Advisory Board electronic meeting policy, members may recall that this is a document that's required under FOIA for every board and commission to adopt an electronic meeting policy. So this is an adjunct or annex to the bylaws. We can adopt them both together since they're being basically amended together at the same time. Just to flag that there are some changes that are likely to be forthcoming, and we will we'll probably need to update the electronic meeting policy over the next 6 months. But at present, we don't have any guidance on that yet. So, so I'm proposing that the electronic meeting policy that reflects current FOIA be adopted. Does that answer your question?
Yes, thank you.
Are there any other questions? George, would you like to handle the roll call, please?
Yeah, so Rose, we would need a motion to adopt
I apologize.
the
This is George. I'll move that we approve the amendments.
Thank you,
to the
George.
bylaws.
Do we have a second?
Jim, second. I second. Jim Allman, second.
Thank you. Now, can we have the roll call, please?
We can. So the motion on the table is to approve the amendments to the bylaws. These will take effect after the conclusion of today's meeting. Sorry, will take effect on adoption. So I will do a roll call vote to approve that motion. James Almond.
Yes.
Susan Elmore.
Yes.
Harkey.
Yes.
Kimberly King.
Yes.
Monica Karabanek.
Yes.
George McAndrews.
Yes.
Rose Palmer.
Yes.
Angie Phelan.
Yes.
Lindsay Pickrell.
Yes.
Latoya Roxburgh.
Yes.
Ming Chua.
Yes.
Erica Wood.
Yes.
Christy Zed.
Yes.
Yeah. So the motion is carried. The bylaws as amended are adopted.
Thank you, George. Monica, we need your report on from the nominating committee.
Okay, no problem. So this morning, the nominating committee met that consisted of Judge Almond, Angie Phelan. I don't know if I'm pronouncing that right, Angie, I apologize. And myself. We wanted to prepare the slate of officer nominations for your all's consideration. After a very brief discussion, we prepared and approved the slate as follows. Christy Zed, the current vice chair, is nominated for the role of chair. And Lindsay Pickerel is nominated for the role of vice chair.
Thank you, Monica.
You're welcome.
Are there any other additional nominations or comments? If not, is there a motion to elect the new officers?
This is George McAndrews. I'll move that we elect the officers as nominated by the committee.
Thank you,
Jim
George.
Allman will second that nomination.
Thank you, Jim. And one more time, can we have a roll call, please?
So the motion on the table is to accept the slate of officers as presented. Zed as chair and Lindsay Pickerel as vice chair. James Almond.
Yes.
Susan Elmore.
Yes.
Kathy Harkey.
Yes.
Kimberly King.
Yes.
Monica Karavanik.
Yes.
George McAndrews.
Yes.
Rose Palmer.
Yes.
Angie Phelan.
Yes.
Lindsay Pickerel.
Yes.
Latroy Roxburgh.
Yes.
Ming Trong.
Yes.
Erica Wood.
Yes.
Christy Zed.
Yes.
So the motion is carried. We have a new set of officers. Christy Zed is our new chair, and Lindsay Pickerel is our new vice chair. Those officers will take effect after the close of today's meeting.
Congratulations, Chrissy
Yeah.
and Lindsay. I appreciate your stepping up to the plate, and we look forward to your leadership. Okay. The Legislative Committee appointment. We need to appoint members to the Legislative Committee. I think at the last meeting, Erica Wood raised the point that reconvening the Legislative Committee, which members agreed to, should be discussed today. Can we have some interest in that? As a reminder, the Legislative Committee is tasked with developing for the board approval appropriate legislative proposals and positions to enhance and improve the public guardian program, and being responsible for following legislation and recommending positions for the advocacy to the board for the chair to present to the commissioner. This committee would meet once a year, and we know Erica Wood would like to join, so you may appoint her, but please ask for, I'm asking now, would you who else would be interested? We need 4 more people, and the vice chair, I believe, is supposed to be part of this committee. Is that right, George? And
Yep, that's correct.
I'd like to have some interest before I appoint arbitrarily.
Rose, I'm obviously happy to serve.
Thank you. I appreciate that. So we have Lindsay, we have Erica. We need 2 more.
3 more.
3 more, I'm sorry. there anyone else who's interested? Judge Allman, would you be so kind?
Well, my term, I think, is up in 6 months. That's the reason I haven't volunteered.
Oh, okay. I'm so sorry. I didn't realize that was coming up here so quickly.
Sorry. The next end of terms will be a year from now, so June 30th, 2022. So I know a number of people are finishing up then, but everybody who's currently on the board, apart from Angie Phelan, would be eligible to join the nominating committee.
Does that change your mind, Judge Allman?
Oh, sorry, the legislative committee.
Yes, but you can include me as well.
All right, so we have Judge Allman, we have Erica, and we have Lindsay. Is there anyone else who would like to step up?
This is Kimberly King. I'd be interested in participating.
Thank you, Kimberly. I appreciate that. Is there anyone else? George, would you be interested?
Sorry, you're muted, Mr. McAndrews.
I am going to be retiring from work in January and will probably be retiring from the board at the same time. So I don't think I would be a good match for this.
Congratulations on the retirement.
Oh, thank you.
And you more than welcome to hang around.
Rose, this is Christy Zed. I would be happy to join as well, unless there's an issue with me being here.
Actually, you're on it automatically.
Okay, well, there you go.
So,
Oh, yeah.
do we still need one more, correct?
Yeah. So Christy's there as ex officio.
May I nominate myself? Since I'm not on the, if everyone is okay with that, I will nominate myself. That way I won't be putting anybody else on the hot seat. So I think we need a motion. Can you help me with the slate again? We have Erica Wood, we have Lindsay Pickrell, we have Judge Allman, myself, and Christy Zed. Is that the slate, George? Kimberly, I'm sorry.
King.
Kimberly King. That's our slate. Can we have any discussion about that? Any objections?
Did we get the motion?
I'm getting ready to ask for it.
Oh, okay. Sorry, I'll make the motion. I thought the discussion came after the motion, but yes.
All right, and may we have a second?
This is George. I'll second it.
Thank you. And is there any other discussion that we need to have before we have a roll call? I guess not. So George, would you handle the roll call, please?
Sure. Thanks, Rose. So the motion on the table is to appoint the 5 members named to the Legislative Council Committee. Judge Allman?
Yes.
Susan Elmore?
Yes.
Kathy Harkey?
Yes.
Billy King?
Yes.
Monica Karavanek? George McAndrews,
Yes.
Rose Palmer,
Yes.
Angie Phelan,
Yes.
Lindsay Pickrell,
Yes.
Latoya Roxburgh,
Yes.
Ming Trong,
Yes.
Erica Wood,
Yes.
Christy Zed.
Yes.
Okay, the motion is carried. Members are appointed, and I'll follow up with meeting dates. We'd be looking to meet in July or early August. And just to note that this will be an in-person meeting.
Thank you, George. I appreciate that. We'll look forward to hearing from you. And the next item on, and I do appreciate everyone who is going to work on this really important committee, and it'll be, I think, quite interesting for all of us and to be a more active part in what is happening on behalf of our public guardianship program. I believe there's a letter for public guardianship programs. Do you have a draft? There we go. I think everyone received a draft in their emails as well. The letter is intended to clearly show our programs how much the board appreciates their work and incredible dedication to the public guardianship program. And that helps so many Virginians in our most vulnerable residents. This letter also indicates that the current regulatory changes that DARS is moving forward with, and which board has been briefed on which our board has been briefed on regularly, and have had the opportunity to provide input on behalf of the full and have the full support of the board. This is also the case for the revised contracts that the board reviewed in March. And we'd like to show clearly that the board is supportive of the proposed changes, such as the client to staff ratio and the wait list management. Can we open up some discussion or changes to the letter?
This is Susan Elmore. I would just like to ask that we either include another paragraph or some mention that they also did exemplary work during the period of COVID and the state of emergency since March of 2020. You know, because that provided extra challenges for our public guardians as well as extra work to be done.
Absolutely. That's a good point. I appreciate that, Susan. Looking down through here.
Rose?
Yes.
I'm sorry. Were you going to go ahead and?
No, please go ahead. I was just trying to figure out where to put it.
Okay.
Go ahead.
I thought the letter was beautifully written. I just have one annoying, there was like one word missing that I noticed. On the first page, the second to last paragraph, that starts with "in looking the state fiscal year." Right in the middle, it says the PGP in large part. I think there should be a DUE, D-U-E, right before the in or after part. Thanks. Overall, I thought it was a beautifully written letter, and yeah. Thank you so much.
So may I suggest putting in a line about the response to COVID in this paragraph?
I think that's a good idea.
board is happy for me to craft a sentence on the COVID response, I can add that there. We would like to, if the board is comfortable with that, we would like to send that out after this meeting. So,
Are there any concerns or any questions, changes?
This
This is
Kim.
Susan
I was
Elmore.
just
The
looking
only,
at the list of members. I'm not listed.
I'm sorry, I didn't hear that.
I was saying I was looking at the list of members along the left column, and I'm not listed.
Oh, no.
Is that Kimberly King?
Yes, I'm sorry.
Okay. Sorry, I'll put you in as an ex officio member under Angela Harlow. Sorry about that.
this is Susan Elmore. Can we request that the board members get a CC copy of this too, that we could share as appropriate?
Absolutely.
Are there any additional comments or questions? If not, may I have a motion?
This is Susan Elmore. I suggest make the motion that we George craft a letter or add any additions to the letters we discussed, and that it be sent out to the program directors with our sincere thanks for all they do.
Thank you. Is there a second?
This is Angie Phelan. I'll second.
Thank you. And one more time, George, roll call, please.
Yes, thank you. So the motion is to approve the letter with the amendments discussed and to send that out to the board. Sincere thanks. Program directors. James Almond.
Yes.
Susan Elmore.
Yes.
Kathy Harkey.
Yes.
Kimberly King.
Yes.
Monica Karavanik. George McAndrews.
Yes.
Rose Palmer.
Yes.
Angie Phelan.
Yes.
Lindsay Pickrell.
Yes.
Latoya Roxburgh.
Yes.
Ming Truong.
Yes.
Erica Wood.
Yes.
Suzette.
Yes.
So the motion is carried, and I'll make the appropriate amendments and send that out to the Public Guardian program directors and make sure the board is CC'd as well.
Thank you so much, George. Next up is Patty Meir with the Public Guardianship Program updates.
Hello, hi everyone. First, I want to tell you how much I appreciate the support in your letter. Thank you. I appreciate your recognition of the work we've been doing here internally at DARS and the work done by our wonderful, wonderful programs. I'm grateful, and I know the providers will be very grateful to see the letter. So thank you very much. I want to bring you up to date on our client data. You recall that the PGP has funding for 1,049 slots, which we have contracted among our 13 providers who serve the state. As of March 30th, 2021, which was the end of the third quarter of the fiscal year, Reports that we received from our local providers show that the program had 978 active clients with a court order in place establishing the public guardianship. 60 offers were outstanding to individuals who had been accepted for public guardianship services by the local program, but a court order is still required to begin the guardianship process, or to begin the guardianship. That leaves us with only 11 open slots. 10 are unrestricted slots. We have no open DBHD. We had no open DBHD SID slots, and we had one DBHDS MH slot. At the end of that quarter, the programs that had openings in their unrestricted category had enough people on the wait list to fill all of their open slots. So I think it's just an in-motion issue. Things are moving. During the third quarter of 2021, we had 21 court orders entered appointing a public guardianship program as their public guardian. And we had 24 client deaths. As far as the wait list goes, I've told you about some of the strange idiosyncrasies with our unrestricted list currently. The programs are keeping those lists a little differently. Our new contract, which goes into effect on July 1st, will bring everybody into the same system for maintaining their wait list. So we'll probably, by the end of the the end of the first quarter of 2022, which is in October, we'll have that information. We'll be able to provide a more a number that's a little less apples to oranges. But I'm going to go ahead and tell you what the number is. Right now, we appear to have, at the end of the third quarter, based on the reports we were receiving from the local providers, we had 550 individuals on the waiting list for an unrestricted public guardianship slot. And last week, there were 152 people on the DBHDSID waiting list, waiting for a public guardianship slot. And of course, those numbers are increasing. You're aware that in FY 17 and 18, we had significant increases in the size of the program. For a while, we had basically taken care of the DBHDSID list, and there were only a handful of people waiting, but that grows constantly now. So that's where we are. I'm going to let Betty in just a minute give you an update on the COVID infections and where we are on that. But I did want to tell you that as a policy matter, we had advised the local PGPs that they didn't need to make in-person face-to-face visits, but they should do it where possible. We had taken the position that we wouldn't be requiring those actual in-person face-to-face visits under the contract until June 1st. So the choice really rested with the provider. They could decide to do an in-person face-to-face visit or some sort of alternative monthly visit, which they document and keep a record of. And, you know, as I told you, they've been doing a fantastic job during COVID. Most programs were reaching out to their clients more often than once a month because of the difficulties. But in April, I'm pleased to say we were able to announce that we would expect those monthly face-to-face visits to begin again on May 1st as opposed to June 1st. And this was a result of policy changes at the CDC and CMS that were issued in March and April, which were outlining the criteria under which long-term care facilities should reopen to visitors. And there was a real shift from absolute closings of the entire facility to being more individualistic about restricting visitors to particular patients who were experiencing COVID. As opposed to shutting down a whole facility. So those exceptions were extended to our program. I mean, obviously, if we're trying to follow the guidance of CMS and CDC, and the Virginia Department of Health had issued a statement saying that they thought that all long-term care facilities, recommending that all long-term care facilities, and that included specifically group homes, follow the guidance of CMS and the CDC. So Betty, you want to jump in and talk about the COVID numbers, and then I'll come back and finish up with what we've been up to.
Certainly. Thank you, Patty. The COVID data I am providing, the information that I'm going to give you is cumulative data. So the numbers actually cover from the beginning of the first reported COVID case, which we started tracking with our programs beginning May 1st of 2020 through today's date, which is June 22nd, 2021. We have had a total of 227 reported cases. Of those cases, 195 people have recovered. We have had 25 COVID deaths. And I do want to emphasize, we've also had 7 deaths that were not related to COVID. And I'm reporting that number because these people were listed as, of course, having COVID, but the reason for the death was not COVID related. So again, that was 195 people that recovered, 25 that passed due to COVID, and 7 that passed that were not related to COVID. We do not have any outstanding cases now. And I also have further good news that we are not getting reports of new COVID cases. So we're definitely seeing improvements throughout the state. The last email of a reported case that I received was on April 5th of 2021. So again, we are definitely seeing improvements, and having 195 people recover out of 227 was really great. So again, great reporting on behalf of our public guardian programs. Are there any questions about the COVID numbers? Thank you.
Thank you, Betty.
Okay, so let me just get back to telling you some of the other things we've been working on. We are in the process of planning for our statewide training, which is going to be held at the end of September, and identifying speakers. Kathy Harkey gave me some help with that, and I am very grateful. Also, Christy Zed. Those were successful suggestions that you made, so thank you very much. We're moving forward. I'm very excited about it, and we're really hoping that all will continue to hold, and it will be a live conference this year, because that's just such an important opportunity for our providers to sit together and talk, for the Guardian reps from various programs to get together to talk. I think it's something that we've been doing for years in person, and I think people will be very grateful to get back to it. At least I'm hoping so. The new contracts, we distributed those. We did trainings on those to all of our programs, and we got some initial questions. We worked through them, but nothing that required major substantive changes. And so we've got it finalized and ready to go. It's in the queue with our procurement people to distribute. I think it's going to go out this week. So that's very exciting. And then, as you all know, we've been involved with the JLARC study. Last November, the General Assembly directed the Joint Legislative Audit and Review Commission to undertake a study of guardianship in Virginia. I've had several meetings, and other people at DARS have had several meetings with JLARC to discuss the public guardian program and to share data about the program. They've come to us several times. I sort of suspect that that's because we keep data. I don't think there is data with respect to private guardianships in the state. I don't think there's any centralized system of maintaining data. So I think we've been helpful to them. I know that JLARC is now in the process of reaching out directly to our program directors and to the guardian representatives themselves. And I know that they were going to contact some of you, if not all of you, directly to talk about your experience. So thank you very much for your support and whatever you share. We're looking forward to whatever constructive criticism they have to offer, suggestions for improvement, and then just reading about what they come up with for guardianship in Virginia generally. That's it's a tough, big issue, and takes a lot for someone who doesn't work in the system to kind of wrap their head around. So appreciate anything you do to work with JLARC to help them better understand guardianship in Virginia. Any questions about any of that?
Patty, this is Erica. I have a question.
Yes, ma'am.
I was interested in your report about the providers being able to meet in person live with the clients now, and that's of course so good. I also think that the work they did previously, meeting with the clients remotely, was good during COVID, and wondered if you thought that some of that increased remote activity would continue as a supplement for the live meetings.
I don't follow what they do each and every day with each and every client. What I am always surprised, not surprised about, delighted about, is the level of commitment that I see each Guardian rep has with their client. So I imagine that there will be some Guardian reps who do choose to continue to supplement their monthly visits if it's a way of contacting people. I think it was in some cases inconvenient for providers, however, the residential providers who would have to arrange the visit. You know, they have to bring the phone in or help someone hold the phone, help them hold the computer, get it all turned on. So I don't know how that'll play out exactly, Erica. We'll just see over time when we look at our program notes the next time.
Thank you. I think that there's been some national discussion about this hybrid idea, whereas the Guardian meetings would be live, but now that we've learned to use the remote channels better, that can supplement and increase.
We'll bring that up at the next program. I'll bring that up at the next program directors meeting and just see what people have to say about it. Thank you.
Thank you.
Okay, well, Rose, should I just go into my next presentation then?
That was exactly what I was going to ask you to do. Thank you.
Okay. So this is a difficult topic, and I would like to begin by saying to our sister agency who's here, DBHDS, who does so much to support this program, and we share so many clients. Nothing I say here today is intended to be criticism of you or the great work that CSBs do. I talk about this topic today because I think everyone's aware that it is the state of Virginia is having a great deal of crisis around mental health services, and particularly the situation at the state hospital. It's affecting our programs, so it seemed like something that we should talk about. So in an article in the Virginia Mercury dated April 21st, 2021, regarding the staffing shortages at state hospitals or mental health institutes, DBHDS Commissioner Land explained that while state hospitals were originally designed to serve chronic long-term patients, TDO, or acute admissions, have increased at state hospitals at a rate that's unsustainable, was the word she used. The article indicated that at one point in fiscal year 2021, which isn't over yet, will be next week, the census at the state hospitals was 112% of capacity. In addition, the article indicated that state hospitals are facing significant staffing shortages. It was reported that Commissioner Land had said that facilities across the state are operating at 65 to 75% of staffing. And then in FY 2020, at some facilities, more than 30% of the direct care positions were going unfilled. At Eastern State, for example, there was a 37% vacancy rate among nursing staff and a 52% vacancy rate among physicians. These patients, many of whom are referred to the Public Guardian Program, are not easy to serve. They have very difficult problems. Commissioner Land described the current patient mix to be very complex, acute, somewhat assaultive, and aggressive. These patients have not had the advantage of long-term residential treatment that was characteristic of the patients or clients that we accepted in the past. DARS, this program, the Virginia Public Guardian Program, has 98 slots that are reserved for individuals incapacitated by mental illness who were referred to the program by DBHDS, or the Department of Behavioral Health. DBHDS has reserved these slots for individuals who are patients at the state hospitals, typically patients who are approaching discharge. And these 98 slots are handled by 3 of our PGP providers: Bridges Senior Care Solution, District 3 Governmental Cooperative, and Jewish Family Service of Tidewater. But the other 10 providers also deal with the state hospitals. Many clients in our unrestricted and DBHDS ID slots also suffer from serious chronic mental illness and from time to time require hospitalization. Many end up receiving treatment at a state hospital. So the situation that Commissioner Land described affecting the state hospitals is having a very significant impact on our public guardianship clients and our providers. Some of the issues that our providers have brought to me are in relation to admissions. It's increasingly difficult for them to obtain a TDO or crisis admission. They report that it appears to them that CSBs and magistrates, CSB crisis teams and magistrates are interpreting danger to self or others, which is the basis of an acute admission, much more narrowly than they have in the past. Also, there's increasing tension around admissions for individuals who have dual diagnosis of intellectual disability and mental illness, with hospitals and magistrates interpreting the behavioral manifestations presented to support a psychiatric admission as behaviors related to the individual's ID diagnosis, while REACH, the state's crisis provider for ID individuals exhibiting dangerous behaviors, often refuses to accept the individuals into the REACH program because REACH sees the behaviors as related to the individual's mental illness. There are also many issues related to discharge. To find a person ready for discharge at a state hospital needs to find that an acute patient is stabilized so that they're no longer a danger to themselves or others. It appears to our providers that stabilized is being interpreted more broadly than it once was, with attempts made to discharge individuals who are still being held in restraint chairs or receiving medications at the state hospital that they're unlikely to receive following discharge. Also, that there are just simply too few residential providers who are willing to accept individuals with severe problematic behaviors from state hospitals. And those who are willing to accept often appear not to have staff that's adequately trained for people with the level of behaviors that these individuals have. And this is creating significant tension between discharge planners at the CSBs and state hospitals who are understandably anxious to discharge a patient to a facility that will accept the client, while the guardian, who is interested in finding a residential placement that is likely to be successful, pushes back and is trying to find a good placement that will promote long-term stability. And of course, from my perspective and their perspective, doing that serves the system better in the end because it helps prevent the constant churning. Public guardians are part of the support network for this mental health population, but just appointing a guardian does not mean that there are resources in the community to serve these individuals. For our public guardians, the resources in terms of time and staffing that they devote trying to keep these individuals stable in the community are simply outsized. And because of the limited number of resources and the limited amount of funding available to access the resources, they often are unsuccessful in creating any kind of stability for these clients. This is discouraging and has a negative effect on other people who are served by our program because so much staffing is going in this direction. So these are all things I've heard anecdotally from the programs and really from most of them. But I've asked Carol Ewing from Bridges and Dorothy Salomonsky from JFS Tidewater to tell you about some of their experiences. Bridges and JFS Tidewater are our two largest providers. Carol and Dorothy are, without doubt, our two most experienced PGP program directors. Each has been with the Public Guardian program for over 24 years. Both Bridges and JFS Tidewater serve some of our most challenging clients. This isn't a case of Public Guardian programs trying to cherry pick and weed out difficult clients. These two programs have no problem stepping up to the plate when it comes to very, very difficult clients. So I can't think of anyone better to give you an assessment of how this situation at the state hospitals is affecting the Public Guardian program. So I'm going to turn it over to Dorothy now, and when she's done, Carol Ewing will finish up. So thank you.
Hi, everyone. I'm really pleased to be able to speak to you and talk about some of the difficulties that we're having with our most challenging clients. But when I was speaking to some of my representatives that work with the clients, they all agree that we want to continue to serve these people because whatever we're doing, we're helping them and helping the rest of the citizenry of Virginia because these people are very difficult out in the community and need our help. And before I'm going to talk to you about three clients, give you three sort of really, they might be a little extreme as far as time, but these are things that we encounter that I think that everyone should keep in mind. I think that one of the biggest obstacles that we have is that the role of the guardian is so misunderstood. They think that we're the guardian, just like if we were guardian of a child, that we could pick these people up and have a place to put them, take them home, whatever they're thinking, they'll call and say, you know, this person's having behaviors, come get them. And that's not something we can do. These clients are mobile adults. As you can see, when I tell you about these three case studies, they're very young. And they want to live their lives. They want to, when they're out in the community, they want to live the way they want to live. And that makes the role of the guardian as a substitute decision maker just that. You know, we can try, but, and not a lot of people know that the guardian can't enforce medication for psychiatric illness. We can't enforce psychiatric medication, therapy, or treatment unless the people are detained, which means they're in the state hospital or in a hospital under a detention order. So they might come out of the hospital medicated, but we can't force them to take the medication after that. People say, well, why don't you put them in a locked unit? Well, because locked units are only for people with a primary diagnosis of dementia, which, as you will understand after I talk about these clients, that doesn't fit. So the only other type of facility that we can suggest is a limited egress assisted living facility, which A, they're very few, B, they're very costly, and these folks need more supervision because they're going to still want to go to the store. They're still going to want to go to the 7-Eleven, whatever, and they need someone to go with them. They need a companion. They need an aide, and there's just not money out there for that, or the money's just not available. So I want to tell you about three clients. I'll first talk about Miss V. Miss V is a 25-year-old female who came under JFS public guardianship in 2017. She was in a state psychiatric facility until December of 2020, when she was discharged to an assisted living facility without our knowledge or consent. The hospital that she was in They knew she had a guardian. Our case managers, our guardian representatives are in the facility all the time. But just something fell through the cracks and she was discharged. We didn't have an opportunity to participate in the discharge plan. And since that time, since December of 2020, she's been readmitted and discharged, readmitted to the state hospital, discharged twice. So not that it was a bad placement, it just was not the kind of placement that she needed to be successful. So we expected this will keep happening with this client. So another client I want to talk to you about is Mr. W. Since 2016, 12/15 to now, we've spent 96 hours working with this gentleman. Since January of this year, we've spent 25 hours working with this gentleman. That is a lot of staff time. He's 45 years old. He is a 45-year-old man with a major neurocognitive disorder that resulting from HIV. He has schizoaffective disorder. His manifestation of his brain injury from the HIV is that he's hypersexual. He will molest, expose himself. He's been arrested many times, long criminal record for these sexual behaviors. If he's in the proper setting, he's redirectable, and he's compliant when he's in jail or in the right setting. He's on probation for 99 years and he's under 50 charges. So we feel that part of our role as the guardian in this case is to make sure that not only is Mr. W safe, but that the rest of the public is safe, because he can't be left to his own devices because he will offend again because of his brain damage. He was in the state hospital. He went to an assisted living facility. He was arrested for sexual battery and involuntarily committed. From the commitment, he was sent back to jail. Well, when he went to jail, he lost his funding because he would have had discharge funding from his hospital admission. But now that he's in jail, the jail is expecting us to find a placement for this gentleman. What he needs is a delayed egress, which I explained before, with one-on-one supervision to keep him from eloping. And if he elopes, he will offend again. But it's the funding and the proper placement is the problem. And like I said, once he's out of state hospital, the funding is gone. And then you have to, we're trying to go to bat to make sure that he's safe and the public's safe. And this is a statement from my guardian representative who's been working with him all this time. Having a guardian, public or not, ensures that he stays off the street the majority of the time. He is a danger to himself and others while on the street, which is his preference. He would like to live on the street. All we can do is file a missing persons report and advocate to him to have a safe placement from jail. The key is restoration of his funding and extra funding for a one-on-one with a long-term placement. That is really the most difficult thing, is the long-term placement for people like Mr. W. Mr. O is a very, very, very sad case. Since we got him in 2018, we spent 248 hours on his case. Since January, we spent 37.25 hours working with him. He's 20 years old. He's a dual diagnosed person with schizoaffective disorder and autism. He has complete lack of impulse control. There are no placements suitable for him because he needs a one-on-one supervision. In his last home, he ran away and assaulted the first person he saw at the 7-Eleven. He was taken to the hospital where the judge wanted to release him because there was no clear and convincing evidence that it was not his developmental disability causing his violent behaviors. It took intervention by the city attorney with the judge at the hospital for him to stay until he was treated for his mental illness. He went back to a group home, but he has gotten a discharge notice because he needs a customizable rate and a one-on-one to keep him and the public safe. Because if he has a chance to elope, he will, and he has no impulse control. I have a timeline given to me by the guardian representative of all of the things that we've done for this gentleman over the course of time. But as you can see, just from these 3 case studies, it's really no one's fault. You know, it's not the CSB's fault, it's not the hospital's fault, it's not our fault. It's just a lack of appropriate places for people to live with the proper supervision so that they'll be successful and safe. So if you have any questions, I'll be glad to answer them, or Carol can take it from here.
If I could just interrupt. Thank you, Dorothy. One thing I want to make clear, because it was a learning experience for me. Dorothy talked a lot about needing the supplemental funds to get services in place for somebody. It's not like there is an easy source of supplemental funds. Usually the extra dollars that come through DBHDS or the CSB as discharge assistance plan dollars, which are available to help the state hospitals get people out of the state hospitals if there are extraordinary barriers to placement. But those funds, there are limitations on them and how long they're available and your ability to get them. And then if problems develop after the person's been discharged and there is not one of those plans in place, you can't get it at that time. And so you have to take another vehicle through the CSB to get funding for extraordinary rate. And of course, for individuals who are not intellectually disabled, it's a different part of the CSB. It's the mental health side, which it is a little bit more problematic. The point being, we don't have the dollars. It's not like this is something that DARS could put the money in to cure these problems, or our public guardian providers have access to a source of funding for these dollars. It's a challenge. And probably Christy Zed knows a whole lot more about that than I do, actually. So,
yes. How much time do you have, Patty?
yeah, it's complicated. Can we leave it? Can we say that, Christy? It's very difficult.
Yes. Yeah.
Okay, so now I'll turn it over to Carol.
Can I have a question for Dorothy? This is
Yes.
me. Dorothy, early case, you say case 1, Miss B, discharged without our consent. It is a standard process, or they have to inform us, or just legally just discharge without let us know? And could you advise us on that?
Yeah, it is a standard. The discharge process is does take some time, and we usually, or we should be consulted so that we can weigh in on the placement. Usually, if it's someplace we haven't been to before, our guardian representative will travel to the place where the discharge is supposed to be and make sure that it looks like an appropriate place. It's not that this place wasn't appropriate. It just was the fact that it didn't have all this. It didn't have the security and the services. It's a fine place, but these people, some of these people have unusual needs. And so you really have to be thoughtful. And as Patty was saying, sometimes pushing back, like, I just don't think that this facility is going to be able to, and this was a group home, assisted living home, is going to be able to really serve her needs so that she doesn't have to keep having this revolving door back to the hospital. But in defense of the hospital, there are just not that many places that will, have that kind of service in their facility to have enough staff and enough experienced staff to take care of somebody with her needs.
So in other words, that there is a misstep that we need to close that loophole. That's my point of view. Is that the right thing to say?
Probably. I mean, I think we have a very good relationship. At least my staff does with the state hospitals. We're in and out of the state hospitals all the time. They know us, we know them. And sometimes, they'll just have a change of staff and they didn't let us know. And this has happened a couple times that people have gotten discharged and, we didn't get the input. So I think the input into the discharge by the guardian is really an important step.
Well, and
thank you.
I mean, the odd thing about it is that it means the hospital is discharging the person on their own signature. And they're signing the discharge papers. And of course, this person has been declared to be incapacitated. So there should be some system in the hospital that prevents that from happening. And although I know people work very diligently with the state hospitals to make sure that doesn't happen and their processes are correct, with the kind of vacancy, staff vacancies they have and the shortfall in staffing, I think that's creating a lot of problems and chaos, in regard to some of these details. So.
This is Kim. Can everyone hear me?
Yes.
With DBHDS, I just wanted to briefly, without going into a lot of detail, definitely thank you for sharing these concerns, and didn't hear anything that was particularly surprising. Yes, there are several challenges that we're all working together to try to address, and specifically DBHDS. But I wanted to address a few things to just let you know that there are currently very specific things happening, and I definitely don't know all of them. Currently, there is a work group that's convened due to Senate Bill 1304 that's specifically looking at the discharge process itself from the state hospitals, working on recommendations and ways to enhance and improve that process. So that's currently underway. Additionally, there are enhanced case reviews with the state hospitals every Tuesday that includes the commissioner and a deputy commissioner, assistant commissioner, other DBHDS leadership to specifically work with the hospitals and the CSBs on cases that they bring because of significant or intensive support needs or very specialized challenges with finding the appropriate placement. So I wanted you to know that even on that level, cases are being specifically heard, discussed, and kind of worked on to ensure that we develop a good plan. As you mentioned, there are funding sources for some of the more challenging cases, and you all didn't mention, but specifically for the IDD population, there's crisis funding, and the turnaround time for those funds are much quicker and typically are meant to kind of fill in that gap while you're waiting for things like the customized rate. We, the community resource consultants with DBHDS, in addition to myself, transition specialists, have also been participating regularly in the census management calls and trying to assist with that process to get the approvals and the decisions made quicker. But I will say that one of the things that we're running into is frequently the providers are not providing the documentation that's been requested, or, recently the process converted to something that's automated versus the paper application. So there has been, I guess, somewhat of a learning curve with that, but we're working to try to make that process move a little bit faster. Interesting, the case you referenced regarding Mr. O, I'm very familiar with that and actually was in conversations with his provider specifically before he was discharged. And I don't know if you all are hearing this, but the staffing shortages within our hospitals are also being seen by some of our community providers. And that provider in particular was discussing just the difficulty with maintaining staff. So what has happened, throughout the course of this pandemic is even our providers that really were having a lot of success supporting these individuals are having a very difficult time hiring and maintaining staff. And there's any number of reasons for that, some of which are people opting or needing to stay home because their kids weren't in school. And then, the unemployment and things like that, being able to sustain them so that they, could be at home with their children and not work. And so there's several things that are affecting that. So we're also looking at ways we can assist with that and are hopeful that staffing ratios will increase. There are RFPs going out to build capacity for more specialized homes. I know that there's partnerships being formed with large organizations and agencies, even on the mental health side, to be able to support some of the individuals who need medical support, but perhaps have behavioral needs that some of the, regular assisted living facilities or nursing facilities can't support. So there is active work being done to build capacity and address some of those concerns. So again, it's being felt on all sides, but wanted you to know that DBHDS is actively working on several different levels to address some of these concerns and fill in some of these gaps. One of the questions I do have is what level of discretion does a PGP have as far as supporting someone outside of their normal catchment area? I was on a call yesterday with State Hospital, and there's a gentleman with some pretty unique support needs, and the liaison believes they have found a provider who may accept him, but it's outside of the catchment area of the guardianship agency that's supporting him. So sometimes we run into that as a barrier or a concern as well.
Kim, let me speak to that. The 3 programs that have the DBHDS-MH slots, they are tied to particular hospitals and have a right of first refusal to that client. But we refer them to the program that has agreed to serve, and they all serve outside. Those 3 programs all serve outside of their traditional catchment areas. If it happens that the placement that looks like is going to take place is going to happen really far and is farther than the provider can serve, then we will talk to the other 2 providers to see if they could serve the individual. So for example, if you found District 3, which is based in Marion and serves all up and down that Southwest corridor and has lots of facilities, deals with the facilities there. If the person really, really needed to go, of course, they typically take assignments from Southwest Mental Health Institute in Marion. If the person to get services really needs to go to Virginia Beach, it's not going to be something that District 3 can do. We don't pay enough money for them to be able to drive to Tidewater every month to visit a client and deal with all of those issues over there. So in that case, they would most likely, they would have the opportunity to accept the client, but if they said they couldn't because of the distance, then we would offer it to Bridges or JFS Tidewater, whoever had an opening first. There is tension here, and it is the same problem that we will always have with hospitals, is that we don't have emergency slots. It's very difficult for us for getting people out of the hospitals. It's often an emergency. We need them out now and we need a slot now. And of course, our slots get filled and we don't always have openings. So we are not, this program is not the best way to deal with an emergency discharge. To have emergency slots, we would have to get new slots every year, because typically you accept, if they gave us 10 slots one year, they would get filled up that year with people who would sit in those slots for years and years and years. So we would need an emergency allocation of slots every year from the Virginia General Assembly, and we don't have that. So that's another one of the difficulties when you come to us with situations like this. But no, we are not strictly tied to catchment areas. Our program may try to see if they can locate a facility within their service area that would accept the individual. We have lots of experiences with us being successful in finding a placement when the state hospital is not. Sometimes if people know that the public guardian is going to be there to stand beside them and help them deal with that client, they'll accept somebody when they are less responsive to the state hospital social worker making the call. So we sometimes try that, but we do always try to work in partnership to make these things work and find a public guardian for somebody if we think we can serve them. So that's how that is. I don't know if that answers your questions, but.
Yeah, thank you so much, Patty. I'll pass this along. I believe this gentleman is served by Bridges, but the placement they're looking at is in Botetourt County. So, but I'm sorry, I don't want to take up this call for specific cases, but just, yeah, I can relay this to the team that's working on everything. And I guess they could just make sure they're having a conversation and keeping the guardian included and involved in the discussions about, you know, their efforts to find placement.
Mm-hmm. Thank you. Yes, all three of these programs have very large service areas. So they're not like little tiny narrow things. All right, I'll turn it over to Carol now.
Can I ask one question before we go there? Just one quick question. And for full disclosure, so everybody knows, I'm appointed to this board as a member at large, but I do work for DBHDS, but I don't speak for DBHDS. That's Kimberly, so she has to have that. So my question for Dorothy, though, is on the case that was they didn't call the guardian first. Did you all reach out to the facility director or the human rights advocate after you found out it happened to let them know what happened, so that maybe they can do training so that they understand that it doesn't happen again? Or
yeah, we did. We told, you know, we went back to the hospital and said, you know, we were upset that the lady was discharged, and you know, so I think that it's just going to take constant, you know, with new people coming on, there's just, you know, I think the best thing that we do is that we have a constant presence and a relationship with the people that work in the hospitals. You know, remind them that they have a guardian, remind them, as Patty says, they can't sign themselves out. It's happened a couple times, but yeah, and maybe if we had known the placement would have been more successful because she would have not gone to that particular placement. I don't know, but or else maybe she would have just been a revolving door back to the hospital anyway. I don't know, but yes, we did make it known that that was not something that should have happened.
okay, cool. Thank you.
This is Erica, and I just wanted to tag on one thing. First of all, thank you for this excellent and really concerning presentation, and it calls to my mind the program that we have in Northern Virginia called RAFT, the Regional Adult Mental Health Facility Specialist Team, which is there to support facilities at the time of discharge. And the reason that that program was put into place many years ago was this exact reason of the revolving door. And we used to call it the ping pong effect and so on. And there is a study underway now in the General Assembly to look at replicating RAFT in other areas. So it's not a perfect match, because in a lot of cases with RAFT, we're talking about nursing homes, but we're also talking about placements in assisted living. So I think the replication of RAFT, while it wouldn't be a perfect answer, might be helpful to the guardians and to the clients.
Thank you, Erica. Yeah, and I want to thank Kim for going over those efforts at DBHDS. Hopefully in a year, the situation will be very different than what it is now, but we're kind of affected by it now and thought it was important for the board to be aware. So, Carol.
Thank you for having me. I appreciate the opportunity to be able to speak. I'm wanted to talk about an overview of specific problems. I do have a couple of cases that I can illustrate those with. And it's really going to sound like I'm bashing, and I hope no one takes it that way. It's just a factual thing of what we're running into. So there's no other way for me to describe it. Discharges, I'm going to be focusing on discharges from the hospital, admissions to outside of the hospital. And it's become very difficult. I want to explain also what my previous background was prior to working in this capacity, and that was in long-term care. So I have an extensive background both in nursing home and assisted living on the administrative side. When I am told that an individual with a lot of mental health concerns, and forgive me if everyone is aware of all these things, and if they are, you can stop me. And that is the difference in the types of assisted living facilities and the type of funding and what happens with those types of funding. So when we're ready to discharge an individual who may not be eligible for a nursing home placement, which is the vast majority, from a state hospital, I'm going to start with the mentally ill that are not duly diagnosed. The first option always are auxiliary grant facilities. I'm not sure how many people are aware of how auxiliary grant facilities are funded. It's approximately $1,400 per individual, and it's a little bit higher and a little bit lower depending on the part of the state. Northern Virginia gets a little bit more. From that $1,400, one has to pay. So let's say you have a facility that has the vast majority of people are auxiliary grant. They have to pay the electricity for the facility, the food for the people to eat, the maintenance, the payroll, which is enormous. It almost becomes impossible. So what's the first thing that they do? They cut back on payroll because that's the least regulated. No one in Department of Social Services who licenses ALS tell you exactly how many staff you must have. You have to prevent decline. You can't have some quality of health situation that happens that's severe, or they may look at the staffing issue, but it's not licensed. You know, they aren't telling you, you must have 4 people for this many or 2, you know, whatever the staffing ratio is. They're not dictating that, except for a locked unit. There is a little more regulation on that, but not much. So what happens is when that's the first level that's looked at for discharge, because it does not require discharge assistant funding, or the DAP funding it's called, from a state hospital. It's my experience, and I actually ran a facility that had an agreement with Western State. I did exactly what is being done. And so I would have an agreement with Western State, but every single person that I admitted had DAP funding. That made all the difference in the world, because you could increase your staff, you could increase your training, and you could provide the level of care that was needed. When you're limited and you can't get the DAP funding, and the individuals are going to an assisted living facility that is primarily auxiliary grant, it's nearly impossible to provide the care if they have a severe mental illness. And I know that both from personal experience and what's happened with our clients. So that becomes a level of frustration for our program. Several of us are from long-term care backgrounds, so we're very, very familiar. And I try to explain the difference. I understand the need to get individuals out of the state hospital, especially because of the staffing shortages. But I also know that we need to place them in places that are appropriate to provide the level of care so that it's not a revolving door, so that they don't injure someone else or themselves. And I think that's what we are charged to do in our court order. So Bridges tends to be pretty, we dig our heels in and try and advocate so hard on specific issues that I think is people aren't particularly happy with me for. But I also know that I have and I think you all are aware that we have a legal option or a legal obligation to our clients. It's not, not to mention the moral and ethical, but we have a legal obligation, and that's to keep them safe and those around them. That's not in the court order, but I would, as a member of the community at large, I would think we have we have to think of the individuals that they're going to be living with and around, and hopefully that they would be safe as well. So that's one thing, because there's a lot of people that aren't familiar with the difference between an auxiliary grant assisted living and very few assisted livings that have auxiliary grant and a number of beds that are licensed as an auxiliary grant bed also have enough private beds to offset that. And I will tell you why. Because when you walk into an assisted living, if you are looking as a community member and you want to place mom or dad there, and you walk in and half of the home is filled with individuals with obvious mental health needs, those are not going to be the place you're going to go, I want mom there. It's just a fact of life. So what happens is those facilities that have auxiliary grant are generally not rated very high for multiple reasons. And that's a fact. So that makes it difficult when it comes to discharge. So then when you know that, now if an individual doesn't need the extended supports and they can be well served there, we don't have any issue. But generally speaking, if they're in a psychiatric hospital requiring the level of psychiatric services that we see that they're receiving, that's not going to be able to be done real successfully in assisted living that is auxiliary grant funded. And when you get DAP funding, the difference would be that they're paying a private rate to go into that assisted living. And that makes all the difference in the world in the ability of the assisted living to be able to budget to care for the individuals that have these extensive needs. So that's one thing one point I wanted to make. The other thing is it's not just the state hospitals. And I think Kimberly spoke to this. There's staffing shortages all over. I mean, it could be lawnmowers. I mean, but in the health situation or the health care community, it's pretty significant. If they're being paid $15 an hour and you see the signs along the road, McDonald's now hiring $15 an hour, it's with a $2,000 sign-on bonus. And you think about the individuals that are taking these jobs and the level of work and commitment and sometimes danger that they put themselves under, they may opt to go to McDonald's. So there's staffing shortages. And all the things that Kimberly had said earlier absolutely go to that as well, all the other reasons. The other thing that we're finding, and I'll give you an example, we had an individual who was, we received a referral on, and all of the paperwork, any previous place that she'd ever been, she eloped and ended up being put in jail. her biggest issue, frankly, is the elopement. She had been, and she did have, I will tell you, a primary diagnosis of dementia. I'm not sure how she ended up in the hospital, in the state hospital when she did. I don't have that information. Well, she was released from jail, so that's why. But at any rate, she clearly, through all of her history, required a memory care unit. And when we tried to advocate for that, for discharge, which meant that it was going to be DAP funding, not auxiliary grant, because there are very few, if any, auxiliary grant memory care units. We were told, and she'd been at the state hospital for a month and she'd been in jail for about 6 months, that because she hadn't attempted to elope from jail or the locked unit at the hospital, that she no longer met elopement criteria. And so they weren't looking at DAP funding for a memory care unit, yet the history prior to her being in jail, this time, she's been in jail multiple times for this, and being subsequently going to the state hospital, was that any placement she had, she eloped. She was both, had dementia and mental health issues, long-term mental health issues. Trying to advocate for the DAP funding and going through all the, community liaison, we go through the proper sources, and to explain is a challenge. And they tend to get really irritated with us. But we tend to hold tight, and I do believe she's gotten a memory care unit bed at this point. The other thing that we have found is, and I was actually told this in a major meeting, one of our individuals who had been actually in the RAFT program and was in a nursing home in Northern Virginia, they tried very, very hard to provide care for her. She has some very significant mental health needs, subsequently discharged, and eventually, which was kind of miraculous, ended up back in the state hospital, because that's another issue. It's hard. Then she was placed again and ended up in at Eastern State Hospital, and on a commitment, and they were doing a recommitment hearing. This was probably about, I don't have the exact time frame afterwards. I happened to be on that meeting, but it was, 45 days, something like that. She had been in the hospital. She hadn't made significant improvement. And in fact, she was still receiving daily, they were still utilizing daily restraints and receiving daily IM injections. And so there was a commitment hearing that was, our staff member for her actually attended remotely. No one was able to speak. The judge spoke for 1 minute. It was timed. All of her support, or all of the staff that she had at Eastern State, did not feel she was ready for discharge. And this was documented. But he didn't ask to speak with them. And he told the guardian rep at that time that he had gotten I'm so sorry. He had gotten an independent evaluator to evaluate her, and felt that she was ready for discharge that day. And so we were told that day that she needed to find placement. That's number one, impossible. But she was also still on daily restraints. They had to utilize the daily the restraint chair and the IM injections. And we asked, why hadn't that, if we were looking at the potential of discharge, why hadn't that been titrated down? Why aren't we treating therapeutically so that she could be treated therapeutically in the community? Because there's no community placement that are going to utilize restraints or IM injections, few with IM injections because of the potential because of the potential of them refusing it. And we were told flat out in that meeting, I was on it, and Mr. Hobble from DBHDS was also on this meeting, that they did not have the staff to treat anybody therapeutically, and that the only way that they could manage with the level of the number of people that they had with significant mental illness on their floors was to either utilize the restraint or the IM meds. They had no choice. And we had to, in order to keep her there until we could find placement, and even Reach can't take them with that. They don't do, and Mr. Hubble explained that, they can't do restraints or the IM injections either. So they couldn't expect her to go to a group home at that point. She needed to be more therapeutically ready for community placement. So those are two issues, or two examples of some of the things that we were dealing with. The other thing that I wanted to mention as well is this staffing shortage extends, we're going to be talking a little bit about the dually diagnosed, not just to the state hospitals, I think, as Kimberly alluded, to all providers, but also in our crisis homes and our crisis step-down homes, which has caused a fairly significant problem. Not only are they having shortages, but there's a turnover. The individuals who are coming in to replace staff that have been left are needed to work pretty quickly. Yes, they're receiving training, but I would have to say, based on some of the incidences that have occurred, that training, probably through no fault of anybody's, because you've got to get people on the job, are not significant enough to provide the level of care, the therapeutic care that the individual needs. Not everybody. Some of the more difficult individuals require in a crisis home. That's something that we've run into a lot recently, very recently. This wasn't always the case. And then I think we've all talked about, and I think Kimberly also mentioned, that there's not enough behavioral homes, even for the dually diagnosed. And again, we're running into staffing problems and training issues in those homes. We shouldn't send our individuals to a behavioral home and actually have their behaviors escalate dramatically while being treated therapeutically. So at any rate, those are the things that I wanted to discuss. I don't know if I'm looking over my notes. I apologize if there's anything that there's a lot of things covered by Dorothy, so I don't want to double up. No, I think that's it. If anybody has any questions, I'm willing to answer. And I hope I didn't sound super, super, super negative.
Carol, thank you. Yeah, so I think there is, I think it's important to hear from Dorothy and Carol, because I do think there is some sense that a guardian is just a legal decision maker, and that there are plenty of resources, and it's just a matter of matching clients to resources, which CSB staff does, and we sign the paperwork. And that is not the case. Our public guardian providers are there every step of the way, trying to advocate for the client. I'm sure it would be easier if they were just not advocating and just acting as somebody who signed a piece of paper that they were requested to sign. But that's not what the court has charged them with doing. They are they have a fiduciary obligation to the clients they serve. And right now it is very difficult. This population is exceedingly difficult. The lack of community services makes it exceedingly difficult. And I just think it is really important that our board be aware of that and what we are facing and what they are facing on a day-to-day basis of not being able to find resources, people leaving the hospital. And, you know, I know Dorothy faced this in a particular case. The hospital said, well, this person's here on a TDO. The CSB, God bless them, have been trying to find an alternative location for this person together with the guardian before they ended up in the hospital. Hospital saying can't keep them. The facility saying we won't take them back. We issued our discharge notice. Hospital says we have no discharge obligation because they're here on a TDO. We're putting them in the waiting room. And they left. They just walked out into the night. So fortunately, in that particular case, the client himself knew how to call the old residential provider who had taken him to the hospital in an effort to get him discharged. And they felt sorry for him and took him back in the middle of the night. And I know that eventually got resolved, but that's the kind of place where we end up. It feels like we're like all stubborn Zacks standing there. There are no resources and everyone's saying, I don't know what to do. And eventually that falls, I think, most significantly on the guardian, who has the person's long-term interest at heart. And their own selfish interest. I mean, to the extent they can get the person stabilized, it benefits the client, it benefits the public guardian provider as well, benefits the whole social service system. And so I just can't tell you how much work there is to do in this area. And it's important for you guys to know. So thank you for listening, and to our sister agencies. Yeah, you guys have a very hard job that we all have together. So thank you.
This is Kathy. I'm not surprised at all with the concerns like Kim. We've been seeing situations like this for a long time in the mental health field. And I know several work groups have been put together and they're doing a great job. As a matter of fact, I think I serve on one or two of those. But what my question is is anyone researching what other states are doing to address these gaps? Because it is a gap in services for our most vulnerable, our most challenged individuals who do not meet the requirements of placement, or there aren't resources there outside of supportive housing or assisted living. So is anyone studying what other states in the union are doing to address this same type of issue, to gain information on what we can learn from them?
This program is not, but go ahead.
Yeah, I think that's a good question. And one of mine would be, did we share this with the JLARC study group? Because that would be a good opportunity for JLARC to do just what Kathy said, research other states and see where we're filling the gaps. So yeah, if you all didn't share these with the JLARC group, I think it would be a good opportunity. Did you say they're interviewing the program directors, or they have?
They are, Susan. I think their emphasis is more on guardianship generally, not mental health discharges, because right now there's a big concern about how private guardianships work in the state, and is our program big enough, and do we, are private guardians, it's designed to prove, is there enough protection available to wards who are being served by private guardians? I think that's really more their interest at this point.
Excuse me a moment. I spoke at length with Christine Wolf yesterday, and actually she was very interested. I actually did kind of go on this because I had some questions about the survey. I didn't know, there was some questions that seemed a little bit nebulous, and I wanted to make sure which angle, what they were looking for. That was the difficult question. So it was clarified to me that they're really looking at the programmatic policies within DARS and the public guardianship program. But that this issue, which certainly impacts all the guardianship programs and not just those like Dorothy and myself, it was very interesting. She took extensive notes and she asked for me to write down some of those things, which I did. So.
Great.
Yeah, I think that would be good. And I think it would be good for the legislative committee that we just formed to maybe put that on their target list. Is we've got a couple issues that I heard you all say. And one, when you were talking about assisted living, Carol, it's not the assisted living facilities that we go to that have CCRCs, continuing care retirement communities, that have an assisted living place. They very rarely will take somebody that has mental illness that has no income. I
No,
say
they
rarely,
won't.
probably
That's the
never.
answer.
Yes.
Yeah.
So for those on the board that are not aware, there's a difference in an assisted living place. There's the high end and then the lower end, and our folks are in the lower end because they don't have the
Lowest.
income. Yes, lowest. Thank you. The underserved and the low socioeconomic, and the auxiliary grant doesn't cover that. So, you know, you can imagine what we're getting. Years ago, we used to call them the roach hotels because that's generally what they were. So yes, that's one issue with it, is the quality of care, quality of life, and supporting the person correctly when they come out, so that they do have the supports to be successful. And that's what's preventing the recidivism. So yeah, I think that's part of what we need to get in front of the legislators, either through the JLARC report or some other way, is to, there's not enough DAP funding, you all aren't getting it, as well as the part of the public guardian not being recognized in the state facilities. People have to realize that that needs to be a red flag that pops up on the electronic health record, which is one of the things I'll go back and suggest is, you know, there's a red flag that says it's a public guardian. It's not just an authorized representative. The person can't sign themselves out. They're, you know, regardless of how good or great they present, they can't do it. There is a law behind this. So I think, yeah, we've got a lot of work to do, but I think it's going to have to be, General Assembly is going to have to know that you all are having these problems, and that these are things that do need to have adequate funding behind them in whatever mechanism that is, so that we can support the people that we need to support.
And I want to throw just one more thing in there for my clients. The majority of the individuals that I'm speaking about now, and I think Dorothy mentioned this too, are younger, right? And higher functioning. They're on one end, right? They're part of their being is higher functioning. How happy are you to go to a facility where there are primarily older individuals, and how well do you think you're going to maintain your mental health under the circumstances that we've described? And so that's a whole nother issue. And when you're coming from when you're coming from a state hospital for discharge, your options are this: a nursing home, an assisted living with an auxiliary grant, and in very rare occasions, now, it wasn't always the case, but now an assisted living that accepts DAP funding. That's if you do not have an ID diagnosis. You know, if you have an ID diagnosis, the window is open more.
This is Erica. I just wanted to get back to a couple of things the General Assembly is doing. There is a study of auxiliary grants. It was Senate Bill 293 by the Joint Commission on Healthcare, and I don't believe they've begun that yet, but I think they'll be doing that next year. And it's going to take, I think, a broader look on how these types of payments can enhance care overall, rather than just should we increase it by this amount or something like that. And then I mentioned earlier that there's a study underway as to the replication of RAPT, and that's part of the larger dementia study, but it might be that they might look at what some other states are doing in the course of that. So there are little, those are two little places where the General Assembly might begin to get a look-see and where we could have input.
That's fantastic. I'm glad we have a legislative committee now.
Patty, this is Christy Zed. I just wanted to also agree with Kathy and Kimberly that these issues are real, and we're all struggling with the number of issues that were brought forward around the systems, the hospitals, the private providers, the staff, and that there are, many work groups and things in place trying to address a lot of these issues. But I also wanted to add some data. I was recently reading an Open Minds article about the IDD market over the past year with COVID and kind of looking ahead. And it was indicating how hard hit with the pandemic, which obviously we all kind of know that, but that the intellectual and developmental disability population was, and that they noted in this article that 16% of IDD support providers reported that they were closing permanently a program during the pandemic and not reopening. And then prior to the pandemic, there was already the shortage of direct service professionals with a turnover rate of 46% prior to COVID. And so trying to find staff, and keep staff since COVID has been even more challenging. So just wanted to share that with the group as well for informational purposes.
Thank you, Christy. Yes, it's heartbreaking. That is a scary number.
Being a provider myself in the ID side, as well as being one of the few that will support individuals with extensive behavioral health needs, I can attest to the immense difficulty that we are facing. At the time, we have 22 direct support professional positions that are open, and it is near impossible to find people that are going to stay, even if they come on, because, with the waiver rates as they are, they don't support a livable wage. When, I forget who mentioned it, that, you could go to Chick-fil-A and make better money running French fries out to somebody's car. So it's, I know that they're doing, DBHDS has contracted with Burns and Associates to do a provider rate study. My frustration with that is that providers were given an extensive Excel spreadsheet to fill out, and we have less than a month to provide it. So that was a real problem. I did reach out and ask for additional time, and if that was going to be something that would be allotted to providers so that they would get more responses, because quite frankly, I don't think that they're going to get many responses. But the answer was no, that the time frame would remain I think it's the 28th. Providers were given the email on the 9th, that they would take our responses up to a week after. But, I just have real grave concerns that there's just not going to be much feedback. And, this is a direct impact for, anybody providing the supports that are needed, because it's been my experience in the many, many years I've done both DD as well as behavioral health supports, that we have found that the success has been to support people individually as opposed to facilities, because, like Carol said, most of us would not choose to live with others that just share a common diagnosis. And oftentimes what we see that manifests in behaviors is because of that just general loss of choice, what I consider true choice, and ability to control where they live. And so we have had really good outcomes with supporting people that others would otherwise have difficulty or have, histories of elopement and in and out of hospitalizations. But that being said, what we have to do to maintain staff and to maintain the training, the rates don't support it. So, it's great to talk about all this stuff, but until we look at how providers can be supported to remain in business, this is going to continue to unfortunately be a problem. And it's disheartening. And I'm hopeful that these work groups will address this, but we also have to remember that that our state still looks at mental health or behavioral health and DD services is very separate. So you have to look at, where somebody falls within their silo. Are they considered the DD side? Are they considered the behavioral health side? And then there's, then you have to, go from there and look at what's available, what resources are available to support that person in the community. So I know that's just my 2 cents as being a provider that's on the front lines right now, trying to just make it through COVID and just get staffing, because we are desperate.
I'm going to speak to something myself, just very, very briefly. I know Susan knows, or maybe a couple of you that know. My husband has ALS. He is cared for 24 hours a day. I need staff here at home. He's vented and trached, right? I lost 3 staff, and they get paid $17 and $17.50 an hour. I lost 3 staff in 1 week, which is really bad, and it's happening everywhere. So it's not just in, like Kimberly had said earlier, it's everywhere. It's bad.
Well, and just to put in everybody's ear, something else is most places don't pay benefits with this. So they don't pay health insurance, they don't pay life insurance, they don't pay annual leave or sick leave or anything like this. So the $17 an hour, yeah, may seem okay for somebody that only has high school education, but yet is it a livable wage? So we have to, I think, realize when we're talking that our direct support professionals need to have a livable wage that also includes some benefits at some point in time. And yes, to whoever mentioned the article about providers closing, a lot of the day support providers have figured out they don't need to reopen. So, that's one reason why the day support providers on the IDDC side are, closing their doors. And apologize if you hear my other phone line ringing. But yes, I think when we talk to people too, we need to not only say wage, but the wage needs to include healthcare, leave time, so that this can be a full-time profession, not just a side job that somebody takes while they are, working on a degree or because they just need to fill in between jobs. We need to go back to direct support professionals and staff, it being considered an actual profession for them, and we pay a rate that is comparable with benefits.
I want to thank everyone, Patty, Dorothy, Carol. The presentation, though not surprising, is still disheartening. And having worked as a guardian, private guardian, and the problems I faced with shortages before the pandemic, staff shortages before the pandemic, and a lack of caring employees in the profession before the pandemic, I can only imagine now that how horrible it must be to try and find help, especially for individuals who are younger, individuals who are have mental health issues as well as sexual aggression. I've had several of those through my career, and they're horribly hard to replace. They're nearly impossible to protect. And you're awakened often to a phone call going, what are you going to do about this? And how do you fix it? You're the guardian, but how do you fix it? There's just not proper placement for these folks. And I absolutely agree. There's not proper benefits, and there's not proper pay in the facilities. So you're not getting the professionals who are caring and want to be there. You're getting the people who just need a job. And it is a job. It's not a career for them. And they're going to leave as soon as they find something else.
Then you add the added thing of them getting potentially injured on the job because you've got an aggressive client. Who wants that? I mean, let's get real. Who wants that? They have to have a real feeling and a real desire for this work and to be properly compensated, like Susan said, and make it a career. And unfortunately, that's not who is caring for our clients.
No, I had a client break a CNA's nose. So I fully understand what you're going into. I've had a couple who were aggressive towards me, so I know what that feels like. And I just can't imagine facing that day in and day out. I mean, it's one thing if you're going to see a client 2 or 3 times a month, or even once a week. Not being there every day, 24/7 to deal with that kind of thing is entirely different. And it has to have the proper funding. But again, I want to thank everyone for their comments and consideration of this very important issue. And I agree, Patty, that this is something the legislative committee needs to look at. It's something that we need to talk about. This kind of funding and is different from anything we've looked at in the past. We're getting the placements that would have gone up elsewhere. Those places don't exist anymore. So now we have to find places that are prepared, and we've got to find, we've got to find people who are willing to open and run and correctly train their personnel to handle these issues. And that's not a small order.
This is Kathy again. I will say that the General Assembly has, some of them are aware of this. I do know, I believe it was the proposed budget for this year or the special session in 2020. There was 1.6 million in Governor Northam's proposed budget for a loan repayment program for workforce development. And then there was also an amount proposed for enhanced behavioral health and enhanced workforce training. I do not recall if that passed. I look at so many behavioral health issues during the session, but the fact that those were in the governor's proposed budget, I think many are aware of this problem. So if it's reintroduced with sufficient amounts in the next budget, because let's see, we just went through amendment year, so the new full budget will be proposed for 2022. It's probably something to bring to their attention. And I have a feeling I'm going to end up getting involved with the legislative committee. But anyway, I'm thinking if it's something that's proposed and brought about for the upcoming budget, you know, it's possible that it can be addressed sooner than later.
Thank you, Kathy. Appreciate that.
Can I make one more point?
Absolutely.
Sometimes I stick my neck out too. Carol and I do very well on doing that. So yes, good to see you, Carol. You know, I don't know quite how to say this, so let me be a little bit blunt on this. If you all had a person who had a physical disability who needed a wheelchair, you would be able to get that wheelchair under services. Okay, we've got insurance for that. We can go fight Medicaid to get a complex rehab chair. But when it comes to a person with mental illness, whether it's just behavioral health alone, or whether it's IDDD, or whether it's brain injury and behavioral health, we don't have any tools in our toolbox. And that, to me, you know, we're saying those people with mental health, they're still people that need quality of life and quality of care. And so somehow I think we need to get the powers to be, federal, state, whatever, to understand that it's the same. We need treatment for that particular disability. We don't need just to put it in a box and say, oh, you get the lowest end of the ALFs that there are, because that's all we're going to give you, and we're not giving you any funding. So I think we've all got a lot of work to do, whether it be advocacy organizations or state agencies, but we've got to, I think, pull together.
Absolutely. Absolutely. If there are no other comments, I'm going to ask if there's any other business that we need to take care of today.
Rose, if I can just mention, the University of Minnesota's Institute for Community, I think it's Inclusion or Independent Living, is doing a documentary screening. I'm signed up for it tomorrow, but I know they have 2 additional dates, and it is aimed at national advocacy for the crisis that our direct support professionals are facing on a national level. I've seen part of what they've done in the past, and it was pretty impactful. I saw it at the Arc of the US conference several years ago, and I think this is an updated one. I would recommend any of you that are interested in kind of seeing what's happening, because it is not just, like we said, it's not just a Virginia thing. This is a national thing, but it is a conversation that is happening and is becoming something we talk more about. So if anyone's interested, I can forward you the information. And it, like I said, it is a free viewing. I think it's 45 minutes. But they've got some great resources, and it is completely on the topics that we are discussing today.
Monica, would you provide that to George? And George, I would ask you to disseminate that to the board, please. The information on that.
Yep, absolutely. I'd be happy to. So, yep.
Sure will. I'll forward it to you after our meeting.
Thank you so much.
Thank you.
If there's no other business, we do have future meeting dates already scheduled, September 21st of 2021 and November 9th of 2021. So put those on your calendars and make sure that you are planning to, hopefully, we're all planning to be present in September, and it'll be nice to see each other and work hand in hand. And before I adjourn the meeting, I'd like to thank everyone for the opportunity that I've had to sit on the board, to act as secretary, vice chair, and chair now. I have learned a lot, and I have grown a lot with the group, and the need is greater than ever. And I am glad and thrilled to have been a part of this and continue to be one more year to be a part of this. And I look forward to the next year of working with everyone. And good luck to our new chair and vice chair. If there's nothing else, I move to adjourn the meeting. And I think that's, we don't have to have a motion, do we? I just realized. The time of adjournment is 12:35. Thank you so much, everyone.
Thank you
for being there and doing all the work you do. Thank you very much.
Thank you.
Cheers.